Now, Jason, would it stop you from eating the donut?
Probably not. But if it tell me that it's going to tell my doctor that I ate my donut, then maybe.
Oh,
Or if
yeah,
it sent a
that's
message to
true.
Sanjay, it's my doctor, and then Sanjay's agent sent a message back, said, "Hey, Sanjay, looks like you just chowed down on a donut. You realize every time you eat a donut, you get about 1.5 points of risk for cancer. Just FYI. Have a wonderful day."
That's pretty effective. I'm not sure I wanted to text my doctor. All I needs to do is talk to my wife, and then, the hammer will come down. That's over.
Welcome to AI in Healthcare. My name is Dr. Sanjay Juneja. I'm a hematologist and medical oncologist, also known as the Onc Doc on social and news media. And today we have a very awesome, exciting episode. It's actually the first of multiple episodes that we plan on having as a series. And the purpose of this is if you are in healthcare in any capacity and you care in any capacity what the future of healthcare looks like as it relates to AI and tech, we are going to be discussing the couple of buzzworthy news points that are necessary to be on your radar because they're going to change the way that things look, in what we believe to be in short months or years. Today, we have two very special guests. Number one, I'm joined with my co-host, Mika Newton, who is the CEO of xCures. And you are hopefully familiar with him with the multiple episodes that we've had independently. But we have recruited two of the very best in AI when it comes to healthcare in this country. Number one is Dr. Debra Patt, who is the EVP of Texas Oncology, who is ASCO's chairperson of the AI Task Force and COA president. And number two, Dr. Jason Hill, who is the innovation officer at Ochsner Health. And together, we are going to be discussing some of the, again, hottest topics and points in healthcare and AI today. So with that said, very happy to have you both.
Pleasure to be here, Sanjay. Thank you.
Great to be here. Thanks a lot. Of course. So the number one thing I want to talk about is something that hit a lot of headlines, and it was that open evidence creates the first AI in history to score a perfect 100% on the United States Medical Licensing Examination, otherwise known as USMLE. And it did so by basically understanding a whole bunch of stuff from the journals we all read, New England Journal of Medicine, JAMA, etc. I would love to hear first, Jason, what your take on this is, and should we be worried as physicians about what it was able to accomplish?
So I'm going to answer your second question first, Sanjay, and say, no, we should not be worried as physicians. Here's the thing. If Jason had perfect memory and you gave me all the questions for the USMLE and then you tested me on all the questions for USMLE, guess how I would do? I would do it 100%, right? So the thing about humans is that our brains, unfortunately, these little things we have between our ears do not have perfect memory, but computers do. And I think that's one of the things that makes them amazing and great tools for medicine. However, and I was just relating this to several of my colleagues at a hospital medicine meeting a few weeks back, and who are very worried about, AI taking their jobs. And you could think, well, AI could be more compassionate to me. Yes, true. AI could also do a better job on cognitive, workflows than me. Yes, true. But are those things the summation of what a good doctor is? I would argue likely not. And I would argue also that if given perfect context, AI makes perfect decisions, but rarely is life full of perfect context. And so human beings luckily have this thing called judgment that allows them to make decisions and provide information without perfect context. And in my 20 plus years as a physician, I have rarely seen a single patient that I was able to have full, complete understanding of every disease that patient has. So I think AI is an amazing tool. And if you're not using it, you're probably not practicing a standard of care in medicine today. But I would say that is not that is not something that is a replacement for human doctors.
I wonder, Jason, when you say that, I was thinking to myself, and you made a great point there, though, like if you're not using AI, you probably should be using AI in one way or another. doesn't this like actually raise the bar on physicians? Like you have to be a better physician. So if an AI could like remember all of the evidence-based guidelines, so medicine's practice evidence-based guidelines, right? And everybody can do that. Why are there guidelines? Well, it makes it easier to remember. So you can go through a structured protocol, right? Do this, then that, then this, then that. Made it easier for everyone to remember. But if the AI is better at integrating all of those things, isn't it all judgment? That like the memorizing part goes away and it becomes all judgment, right? And so only the people with the best judgment are going to move the needle.
Well, I think it's more complicated than that, because so I would say, does it matter? I would say, well, do opposable thumbs matter? Do tools of any kind matter, right? Our hammers are any tool that we use? Absolutely. But I think we have to remember that knowledge isn't always wisdom. And when we sit across the room from a patient, we take different things from them in that very sanctified relationship between a doctor and a patient. So the knowledge is really important, but it does not supplant the need for doctors and patients to be making those decisions. And I say that, because I'm a breast cancer specialist and I can walk into any room and within 30 seconds figure out what the right thing is to do for a breast cancer. But I still sit there and talk to the patient and get their history and understand their goals of care and, have to sort of take that into account in my assessment of what the right thing is for the patient. So I would say I think these tools are incredible and they work like opposable thumbs, like the hammer that helps me hang photographs in my bedroom as a tool. And that tool I think of as clinical decision support. So not to supplant clinician decision making, but rather to enhance it. And I'll just give you an example. Two examples actually. So from clinic last week, one example, I was seeing a breast cancer patient. She's struggling with depression, and her psychiatrist has decided to try her on ketamine for major depression that's refractory to other treatment. And she said, Dr. Patt, I'm worried, is that going to put an increased risk for my breast cancer? I'd read a few studies and I brought them for you. So, well, I don't really know the answer to that question. That's a little bit esoteric. But let me see if I can use a peripheral brain to help me out. So I brought up open evidence, and it quickly, with a very quick prompt, summarized the evidence for me. And I could tell her that the best evidence suggested that it was safe for her to continue her ketamine therapy without posing a risk to her breast cancer. So we sort of talked about that a little bit, but it may be better. I didn't have to go home and read about it for 3 hours that night. It was just really quick. In another example, I have a young breast cancer patient that had some findings in her brain. The neuro-oncologist who I'd sent her to thought maybe attributed it to maybe it was breast cancer. I said, well, your breast cancer, this would be really unlikely. Is there anything else at all from your medical history? She mentioned to me that she'd had a very bad case of cat scratch disease maybe 10 years before. And I was really proud of myself that my brain could remember that was Bartonella henselae, right? But I said, I know that Bartonella henselae can have some central nervous system effects, but I don't know if they can be chronic. So again, I sort of opened up open evidence and I queried what could some of the chronic effects be. And sure enough, they were concordant with the things that we appreciated in this patient, who I thought was unlikely to have breast cancer in her brain. And so we were able to guide and direct those decisions because the knowledge enhanced my wisdom and judgment in a way that I could integrate those in her care. So I will say these tools are amazing. I think all doctors should be using them. I hope we can heighten awareness to them, but knowledge isn't always wisdom.
So I guess my point is, by the way, I fully agree with you, and I'm not a physician, obviously, but you guys are amazing, right? But I guess part of my point was, if you're not amazing in a world where these tools exist, you're in trouble, right? So if you can't leverage those tools and actually take advantage of them, maybe you're just the liability backstop to the system, right? Which I don't think is anything that a physician would necessarily want to be.
So I think one interesting thing about LLMs is that the research on LLMs on efficiency. So if you look at LLM's effect on computer coding, which I think is probably the most well-studied effect of LLMs and analogous to sort of knowledge transfer, right? It doesn't make the best computer coders better. The best computer coders are actually better than the LLMs for the most part, right? So like really master coders are amazing. What it does is it brings up the bottom third up to the median. And so I don't think that necessarily, I think what it will help to do, and actually one of the things that we're really working on at Ochsner, is how can you facilitate knowledge transfer such that you don't need to have someone who receives 20 years of education managing a problem that affects 30% of your patients, right? So primary care, if you look at the numbers, number of residents graduating into primary care, number of patients aging into Medicare, it's doing this, right? It's not getting anywhere close. And we use APPs a lot of times as a backstop, but like, how then can you, instead of thinking of a patient in totality of a bunch of pieces of knowledge and diseases that you manage, how could you potentially verticalize some of the management of those diseases with someone who may not have 20 years of education, but there's plenty of volume. Like, I don't think that there's getting any shortage of patients, and there's got to be any way that you can agentify and, use an agent to take care of all of those things. So I think the real issue we should be thinking through is how can we offload some of these highly protocolized type of therapies off to individuals who may not require 20 years of education. And that way we can treat more patients, because the alternative, which is what we're doing right now, is just not treating them. We're treating them badly, right?
I would say we do have a supply and demand mismatch. We see cancer is increasing in the young, and the age distribution of the population is changing. So we're going to have a lot more cancer. We have workforce challenges. We do need to enhance our workforce somehow. This definitely will help us solve that problem if we can get people to use it.
Yes, 1000%. And I'll just say, Jason, the way you outline that is really saying it's not replacing anything. It's actually substituting where there is nothing, to where people are kind of part-time or in an oversaturated, overwhelmed way, trying to satisfy something where there's a true, at the end of the day, void. So let's see if we can plug in some of these places, to both you and Debra's point, on what can be satisfied and done with just pure knowledge, and then leave the judgment stuff and the things that are harder for the limited resource, which are physicians. I do want to take a little bit of a tangent, because I think something in a similar manner has not caught nearly enough press, and that's really med-gemma, because Google came out, and I thought it was just insane that they were like, "Hey, you all know what's up. We're gonna go ahead and create this open model where people can use a multimodal AI model to go ahead and plug and play and have to all of your local parameters, the things that could enhance patient care in the long term or even in the short term, the way that we just spoke about." So I would love to know y'all's thoughts, and really maybe Jason first, or Mika, explain what the difference is between open source and an open model, and kind of what your thoughts are behind this accessibility to, what some would argue, democratize or increase the accessibility of these kind of elitely AI assembled solutions.
Oh, I was literally just talking to Pete Clardy from Google last week, who runs up one of their healthcare AI teams, about med-gemma specifically, because I find, so the evolution of AI is not making bigger models, right? The evolution of AI is actually whittling away a lot of the garbage that these models have been trained on and getting them into really fast, really furious models. Med-gemma is a perfect example of that. So there's a good friend of mine that's a CEO in Silicon Valley, and he basically was able to use med-gemma to completely run inference on his device, on his Android. So there was no transfer of information. Mm-hmm. All of the data that he was doing, he was feeding it, which was essentially from a sensor of a glucose management. You can imagine any analogous RPM tool. The device was generating an inference layer, and then it was then sending input back to the health team only when that inference layer was outside of the control patterns. And on top of that, it was actually telling him the data. So he ate something and watched what happened when his sugar went up on his Dexcom. And then he put what he did in a device, and it said, "Well, show me what you eat." And he took a picture of it and said, "Oh, that looks like a donut." You know what you could do instead? You could switch that to a to a Oatly donut. And then here's actually a picture of it. And this is what you can then do. And that would actually half your carb load that you just got. And this is your carb load that you got, right? So it's like taking it that what I always find, diseases that affect us, right, are diseases of choice. I choose to have a hamburger. I choose to drink 4 cups of coffee instead of 2, right? But what I find as a video gamer is that feedback loop, the shorter you can get that feedback loop between decision and information, the more you can influence human choice. And I think the ability of med-gemma and the ability for all of us having these little cybernetic things that hang out with us all day long that are cameras and microphones and computers is that we now have the ability to really close that loop. And I think this is what those technologies are really moving towards.
Now, Jason, would it stop you from eating the donut?
Probably not. But if it told me that it's going to tell my doctor that I ate my donut, then maybe.
Oh,
or
yeah,
if it sent a
that's
message
true.
to Sanjay, it's my doctor, and then Sanjay's agent sent a message back, said, hey, Sanjay, looks like you just chowed down on a donut. You realize every time you eat a donut, you get about 1.5 points of risk for cancer. Just FYI. Have a wonderful day.
That's
I'm
pretty
not sure.
effective.
I'm not sure I wanted to text my doctor. All I needs to do is talk to my wife, and then, the hammer will come down. That's over.
Right.
I want to highlight something you said, just even rewinding back to the other conversation we had just before this about capacity, right? So by 2030, all of the boomers are over 65. So if you think about that, it's all of them. That puts 80 million Americans into Medicare covered lives, basically. So that is a massive population. Like 80% of them, I don't have the numbers exactly right here, but 80% of them have at least one morbidity. And I think it's like a very slightly less number actually have 2 comorbid conditions. We have a stated goal from CMS, right, for some time now to move everybody into value-based care. I think we have 10 million beneficiaries right now in value-based care. So somehow we're going to get from 10 million to 80 million beneficiaries in value-based care systems with capitated risk across the whole healthcare system, and not enough people to do anything about it. When I think about that, I start scratching my head, and the numbers they just don't add up, right? Like, who is going to treat these patients? And it was part of where I have been keying off evidence-based guidelines, because I think there have been, and we could punch this in open evidence at some point, enough studies that have been run on what would happen if we just treated people minimally to the guide, like just the hypertension guideline alone, if we got that actually done as a country. And it's like millions and millions. It's like a crazy number of savings. So how do we do that? And I think what you're bringing up about these micro models, about basically AI and technology everywhere, is probably the only technical solution, right? Like the feedback loops, the democratization of the technology and fitting it in kind of everywhere. But if we're going to do that, it's got to get cheap, right? It's got to get good, and it's got to get really, really, really cheap. And I think we're a really long way away from having AI and AI implementation efficient, right, and deployable enough and trusted enough to be able to do that. And I think that window is like, 2030 is 5 years from now. That is a huge amount of progress that we have to make. And I think it's got to be done pretty systematically. Otherwise, we just won't achieve those goals.
The other thing I think to call out just on this subject, is to be responsible stewards of this, as we all are, is that all of these models are inherently biased by the data that populates them. And just like a study is biased by, the accruals within a given study, I think that, again, that's sort of where our own judgment comes into play. But Mika, your point is so well stated. It's a silver tsunami, I like to call it, that, the age distribution of the population is changing, and we're ill-equipped to manage it.
So I remember a study, Debra, from ASCO from many years back that actually said by 2025, meaning this year, that we were going to be short. I want to say the number was like 2,500 oncologists or something like that. And that didn't sound like a big number until I only realized there were only like 13,000 oncologists in total in the United States anywhere. And that, like, how would we magic up 2,500 oncologists? Has that been resolved? Has any progress been made against that? Do you know?
I mean, no, I think that we have a deficiency in many doctors, and not just doctors, in the ecosystem. And the problem is a synergistic problem, because we do have a shortage of oncologists, we have a shortage of surgeons, we have a shortage of primary care doctors. So overall there's a shortage of doctors, but there's also a shortage of nurses and others. And so for my doctors that are in clinic that haven't had a desk nurse for a year, they're going to be less efficient. And so they're not going to be able to see the same volume of patients in the efficient way. So that the problem builds on itself. And it's a real challenge in healthcare today that we are not positioned well to fix that problem. In my opinion, there needs to be, more investments in getting us to adopt tools to work more efficiently. I think that's really critical. Things like Jason and I were talking earlier that both of our systems have implemented an ambient AI scribing service to try to make us more efficient. That's really an effective way to do it. Using tools like clinical decision support and trying to, have patients navigate their space more easily.
You just touched on a topic that's very near and dear to my heart, which is like interoperability and access to data for lots of obvious reasons. I'd love to talk about that, but you also brought up an interesting point earlier that I was wondering, again, just a question. Is anybody, in the way that Medicare capitated risk is being aggregated, is anybody buying oncology risk and aggregating it today?
Yeah, there are organizations that are risk aggregators that are managing risk. So in oncology, TimeCare, Integra Connect are both managing risk in the oncology population. I'm sure there's others. Those are the two groups that I'm very familiar with. And I think that, if you're a plan, it's really attractive to say, okay, can I work with a company that is going to both aggregate my risk, have, guarantee that I'm going to have manageable risk, and also partner with provider organizations to try to see if they can have solutions to try to improve the health of the patients that they serve. And there is probably utility there because the variability that exists between the clinical enterprises that serve patients is pretty vast. I think that none of this occurs in a vacuum. So, Mika, you can't have all of these measures of health and wellness without partnering with adoption of digital tools to try to help navigate the space, because otherwise you end up having these incredibly important resources like doctors and nurses checking boxes to count beans, paperwork over patients, if you will, trying to manage the administrative inefficiencies of care. I do think that digital tools help you there. I think that there are AI solutions. I know some of us are using them already for things like coding to try to augment coding. And I'll just give it an example. Again, I'm a breast cancer specialist, so when I see a patient, I code their breast cancer, and then I stop there. I don't code all the other stuff that they have. But frequently I'll see a patient that does have other diseases. I don't really take the time to do that. Other people in my organization might have to take the time to do that for some purposes. Like, for example, in the Medicare program, CMMI launched the Oncology Care Model, which is now the Enhancing Oncology Model, which is the value-based payment pilot, the advanced alternative payment model. And so we are in dual-sided risk for that model. My practice is in dual-sided risk for that model. I think in EOM, we're like 24% of the EOM population, just my practice alone. So when you say, oh, everybody's going to go towards value-based care, I will say we did think that was true 10 years ago. In the commercial population, that has largely not been true. But we are there with the Medicare population in the EOM. And I think that there's been a lot of investment in the value for patients in the practice that's really made care delivery enhancements that have been meaningful. But the alternative to that is the MIPS program, right, which constantly ratchets down reimbursement, requires a lot of additional bean counting. You would be interested to know that my practice, that has 24% of EOM participants in my practice, we still have to do all the bean counting for MIPS because of all those patients that we have that are not in EOM. And so, it's we have to help practices navigate better, especially if we want people to be working at the top of their license, because the administrative burden and the burnout and inefficiencies that it caused today are crippling when we need people to be the Olympic athletes of practicing medicine.
So this goes, I think your comments around MIPS and, I guess maybe one question right up front. So are you saying that as the Medicare population increases, you're actually going to see that ratio of risk shift? Like, is your commercial market, or does that stay the same based on Medicare Advantage? versus?
So it depends, if the Medicare Advantage program has chosen to engage with a risk aggregator, so that's their choice. If they choose to do that. And then our practice, of course, is happy to participate either way. We've invested a lot in value within our practice, but I would say we're kind of an outlier in that way because we've been all in with the investments in value-based care. But not to say that other practices don't invest, but we've invested quite a bit.
But you can also look though, like investing in risk, upside risk and downside risk is a very particular muscle that you have to know how to flex at a system, right? So like, yes, risk aggregators are important, but if you think about particularly a little, maybe outside the scope of oncology, but primary care, right? So if you're growing a network of primary care, you have to grow at just the right speed, right? If you're assuming full risk, upside and downside risk, and you grow too fast and you have too many people on your payroll, you lose business. You grow too slow and you have patient leakage and you lose business, right? And so like the problem is not necessarily how you manage risk, but so we do a lot of upside and downside risk at Ochsner. It's a very particular skill set that must be cultivated. And it runs almost diametrically counter to everything else you do in medicine. And so you have this weird point where your people in your population health are trying to keep people out of your hospital, but the people in your hospitals are trying to keep their beds occupied. So like they don't want to work with each other. So like you have to step in and say, well, saving money actually gets us money, and this is how this works, and per member per month. But that only works for our Medicare Advantage patients. So only our Advantage patients get access to our premium discharge prevention programs. But that's not right. Like, why would you give everybody access to that, right? And so you end up in these weird moral quandaries when you have when you have these upside down models of care. And then the other part about it is that, people are really enamored with generative AI and all the cool things that it can do. But managing risk is essentially an actuarial exercise. And the old school AI works pretty good for figuring out who's going to mature into CKD5 and end up on dialysis, right? And so how you're managing limited resources as a business, whether that business is healthcare or selling ice cream at the corner store, you have to figure out where to apply your human labor and where are the areas to best apply that. So I think those are like very particular skill sets that like the vast majority of healthcare systems don't even know that they need those skill sets to do those things. And so I think that's going to be a really big problem. And that's where you're seeing a lot of these risk programs fail, is because they don't understand the mechanics of downside risk and how you have to grow your practice in a very particular way.
I think you hit on a great point there, which is, and I think about this a lot, right? Which is, you're right. The statistical risk tables work really well and have worked really well for a long time. It's not like there's a massive delta there for how wrong they are. And we've been selling life insurance policies and health insurance, or life insurance, probably the best example, for a long time. Those things are wrong when people lie or there's fraud or something like that. But if you put the right input data in, they work pretty well. And we just have to look to the financial success of some of the organizations that have done that on the actuarial side. It strikes me that the AI thing that I'm excited about is all the bean counting that Debra and you were kind of talking about around MIPS and all the rest of it. That does not feel like a good use of human capital to me. And the way that we've designed all of the systems is that's the only one who can do it. And so that to me just feels like the lowest hanging fruit is like, let's, my wife's a nurse. So I was asking her, how was your charting today? And she gives me a very sour look right at the end of the day about how, that's a nasty comment, but I think we have just enormous opportunity there to free up resources and all the rest of it. And it's not the exciting stuff necessarily about AI and decision support, right? And clinical things. It's about, coding and filling in the billing systems and being able to look at.
It's the lowest hanging fruit. It's the lowest hanging fruit.
Right. So what makes me, so this is interesting. So I've been working a lot in interoperability, right? And I think you guys know CMS came out with this information blocking rules and they're pushing interoperability a bunch. And we have a couple of examples, I think, that are worth talking about. Number one, the Care Quality Network, which is a private network, right, of provider systems that all participate in healthcare data exchange. Essentially, I think of it as like an internet of medical records. And then we've seen a pretty strong push by many of the participants on that to move closer to something called TEFCA, which is the Trusted Exchange Framework Common Agreement, because we got to have an acronym in healthcare for it. Otherwise, it's not a real thing. And being participants in that with QHINs or Qualified Health Information Networks as the node partners for it. Whatever you boil it down to, I can tell you from my company's experience, we're getting like 90+% of people's data is actually available on an electronic network, and you can go and get it, which is amazing, by the way. And if you go back to 2023, that was like 70%. In 2022, it was like 30%. So like all of this healthcare it's like a real thing. But when you go and look at what it takes to access it, right? Like what are the regulatory steps I need to get in and use it? There's kind of only 2 use cases that are approved, and then there's a bunch that have been left on the table. So the 2 approved use cases are treatment, meaning the exchange of documents the way, I would go to see a new physician. I want to bring my medical records over. So I sign the HIPAA release, and instead of them having to try to fax all my old doctors, right, and get my data, they can now hit the network and pull it all back into one place. Thank goodness that works. It works pretty well, particularly all of the bigger institutions are participating in it. And so covered entities that have a treatment relationship with a patient can access this. The second way that's working right now and just started working, which I'm personally passionate about, though I'm still trying to figure out exactly what it does, is this idea of individual access. So it's like my right as an individual to get my hands on my own data in an electronic structured form that I could actually feed into. And we were talking about like patients mediating their own healthcare. Like what I need is my history, and I don't need to type stuff into like a spread. Like I don't need to do my own charting myself on my own app in order to do that. That's coming, and I feel like it's coming soon. But we've also left a lot of things on the table. So healthcare operations, right? Payment and reimbursement, population health, research. These are all use cases that also feel like they're super important. And I don't think we have answers for that. In fact, one of the things that we've been trying to champion is like, let's get some answers to how all of that works. And it appears to be tied up, again, in the financial constraints of how those things affect systems performance and all the rest of it. But even with the patient-mediated, talking about digital health, like just imagine you could actually get your health and wellness primary care app to actually know your blood pressures from the fact that I never walked into a healthcare provider's office and didn't have my blood pressure checked, right? I'm hypertensive, so I hate doing that. And I have white coat syndrome, which makes it worse every single time that I go and do it. But boy, you would have seen that a lot sooner in life, or I would have, if I had been able to just download that to all one place.
And I think that there are some things that, again, the low-hanging fruit, right? So you mentioned the operational aspects of medicine, right? The, managing revenue cycle, coding and billing, trying to make sure that prior authorizations get completed. Those kinds of things that, once a doctor has made an assessment and a plan, do you really need a clinician to do that? And the hazard of having them do that isn't merely inefficiency, but it's also burnout. I know a lot of 50 and 55-year-old doctors retiring because of the moral injury of, so much of their job is this paperwork nonsense that is just so frustrating that to get a prior authorization for a chemo for one patient, it's pulling you out of a room where you're talking to another patient about death and dying or a very difficult thing. It's too hard to be in that situation. So, I think AI helps there quite a bit. That's really meaningful. But to your point, I think like patients need nudges too, and if we have our health at our fingertips, it makes it a lot easier for us to be compliant with standard things, like, for example, my scale in my bathroom goes to my phone in an app that tells me all kinds of parameters about my health and wellness. And Jason, it does take me away from the donuts in the morning. Let me tell you, that feedback is really useful. Also, things like if you need things like screening for colon cancer, for, breast cancer, if you need something like a flu vaccine, if you're, in the right age for a pneumonia vaccine, those kinds of things that are preventative health maintenance that can really make a society healthier. It's great because a big problem that we have because of the workforce shortage, because so many people don't have strong relationships with their primary care doctor, simple things aren't happening. Like people can go years without their appropriate cancer screening. They don't have someone saying, hey, your BMI is elevated, you're obese. We need you to exercise and modify your dietary choices to make better decisions to promote your healthcare, like just simple stuff. So I feel like those are things that having this at our fingertips would make us a lot better at. And obviously the complex things too, but there's just so much, there's abundant low-hanging fruit.
Do you think the government should just mandate that? Like, should they just be like, the data has to go? Like, how does that happen? Because
I don't think the government has to mandate that. I think that they have gotten pledges, right, from companies willing to enter into this space and make sure that patients have it at their fingertips. And I think you see that from Google, you see it from Microsoft, you see it from Amazon. And so I think that those things will emerge into customer service, right, where healthcare can be more customer service driven. I think it's actually a good thing if people can engage in it in a meaningful way. Not everybody will, but a lot of people will. So it'll help to solve, I think, a lot of these problems.
Will the providers all take that same pledge? Because I know why the companies will take those pledges. We took the pledge first chance we got, right?
Well, there's two things here. One is like the capability, right? Like, do you have the capability of everybody to hold their healthcare records safe and secure? Yeah, you kind of do now. You didn't really 10 years ago. Like, nobody's like hoofing around a USB drive with all their health stuff on it. But now you've got things like blockchain on your phone, right? It's the most secure anti-crypto technology that could be possible. And we're doing it to sell NFTs, but like, you could apply that to healthcare and it would be amazing, right? Like, that kind of technology is transformational. And then the other part, though, is getting everybody to say, getting the healthcare companies to say, hey, we're going to all work and play well to each other, the EHRs. That's really, you got to have a third party come in, because they're not. Like, we would love to say that they would, but I don't think they will.
I think that there's also, it's just worthy to call out that there is a fair bit of skepticism because of the liability risk. It's not that providers don't want to be solution oriented, or that provider groups or organizations don't want to be solution oriented, but as a healthcare entity, you have tremendous liability risk if there were to be an infraction, a data leak in some way. Whereas if you are a business associate, someone that's serving you, serving your organization, serving your patients that you have a relationship with, their liability risk is very small. And so, I think there's fear that unintentional things could potentially happen that pose really disproportionate liability for being a good actor. That's tough to manage. And so not to say that it's trivial, because obviously data leaks aren't trivial. We need to be very protective of healthcare information. But being relatively new in this space, I think that organizations struggle a lot with trying to manage wanting to partner to offer more services and to be more solution oriented and being more conservative because of that liability.
I think you're absolutely right about the liability thing. I think I saw it in discussions we had around these individual access services and the need to basically validate identity, right? And I think, Jason, your point about blockchain, like we have things like Clear or ID.me, like already, like we all know how to use them, but then everybody wants to re-authenticate. So by the way, if you have the user like authenticate themselves 30 times, then what was the difference? Like, it's like no one's going to do that.
Well, I'll give you a quick example that's really interesting. It kind of gets to, what Debra was saying. I was on the phone with the Apple team a few weeks back because I was really interested in getting the data that they get from their watch to help our doctors to figure out, well, if I know someone's having atrial fibrillation, like I would really love to get them, and they're one of my patients, I would love to get them scheduled for an ablation and get them on with our EP team. Or if they're not controlled or their medicine, I'd love to know that, right? So I go to Apple and I talk to their team and I say, hey, you guys, and they're like, yeah, all you got to do is install an app on your phone. I was like, every phone? And they're like, I was like, yeah, hundreds of thousands of patients. Every single one of them has to have it on their phone. And they're like, well, you can do it through MyChart. And so then I go to MyChart team and I was like, well, hey guys, we could just turn on this thing. We could automatically feed the data in. And they're like, no, our compliance team told us we can't do that. And I was like, well, why not? Like, why can't we do that? They're like, well, what happens if someone has an event and we don't see it on the phone and the doctor doesn't see it, and then that leads to a liability. And so to me, I'm like who cares? Right now, we're not even seeing anything,
right.
And we're literally relying
more.
on the patients.
Right.
You'll be better net than you are now, right? But I think to your point, Debra, like there's this perceived risk of liability that sort of gets in the way. And I'll give another quick example. And it's all software. So I don't want to use the word hacked, but we devised an alternate solution for receiving CGM data from some brand name CGMs into our results section of our Epic chart. I have some very smart software engineers that work with me. When we did that, we found that data existed and it was populating one single row in results review. And if you know what CGMs do is they provide data every minute and a half, which is essentially 1,400 times a day times 365 days a year. That's a very heavily populated row. It broke results. It actually broke our entire Epic build when we did it. And so it's like there are these hurdles that exist, right? Like where there are software and technical hurdles, there's compliance hurdles, which just drives me crazy because like the information, the things that we all wear carry constant telemetry about our health to them. We could create feedback mechanisms, but the people that are individuals or groups that are bold and who will go out to help to try to overcome these hurdles, be they technical or be they, structural or monetary, are going to be the people that win in this space. But until you identify the hurdles even exist, and you sort of like don't do the dealer thing in Las Vegas, where you're like, all right, I'm out. You're never going to be able to start to climb that hill because Apple is not going to. I love Apple. I think they're amazing at creating amazing products, but they're going to need, they don't understand that landscape the way that healthcare does.
And they're not willing to make the leap because of the liability risk. And let me just be totally transparent that liability risk is not a fictitious one. It is not your compliance and legal team being overly cautious. Like, it's real. That's a real risk of liability. And so you need to manage it. But I wonder how we devise solutions because, like, is the best way to do that? And I think this is where policy, and there's a great interest, right, in having policy evolve to facilitate good digital healthcare AI solutions. I think there's a large effort by the administration to do this. And how can we get patients to actively opt in or passively opt in to have to actively opt out to try to accept limited liability to benefit from some of these tools? Because I think, to your point, Jason, more would be better, right? Because it would give us the ability to have greater understanding to your patients that have arrhythmias that are just out there doing their thing and haven't yet passed out, but probably will, because they have a new arrhythmia, and you would be better at serving their health. And so what I think, and I think this is a real interest, like I don't know if you guys saw in February, there was an executive order that they're making a advisory council really just to talk about some of this stuff, how to craft policy to try to create better information sharing, to try to craft better the ability to use different tools to manage the health of populations, to try to manage risk in Medicare Advantage. So I think that, they're the problems, and I think they're going to need lots of people to help to find the right solutions.
Well, I'm gonna steal a phrase out of your book, Debra, and you've said, "Don't let great be the enemy of the good." And I think that is something we have to keep in mind, especially when AI models and tools are coming out, and they might hit 85%. You might have some ball drops, but then you look at what the current state of affairs is right now. I think we live in a world where any liability is a void, even if it's 40% without it. I don't want to just be 80% and 20% be liable. So even though it's a doubling of capture or benefit to society, it's still the fact that it's 20% short of what you may miss that will somehow just preclude that extra 40% of a benefit. Now, I'd also say, one of the things that blockchain, I've had this conversation in the past too, allows when it relates to somebody sharing their own data or the multiple players that led to that data. So say you had the sequencing company that has the data and the patient that opted in. It seems for whatever reason, right, capitalistic, society or not, whatever it may be, people have a problem with sharing in part just because somebody else is going to make money off of it. So now the thing is, if in a fractional capacity on blockchain, you're able to pay fractional reward in some capacity to the patient whose data it was, to the hospital center that had the wisdom to be able to order it, to the company that ended up doing the test. Now, I think at least for those that are satisfied with, well, they're going to make money on it, and that's the primary, endpoint of why they don't want to share. I think it could be an interesting, turn on how eager people are if somehow that's amassed or otherwise. And I'll tell you one thing that I haven't heard yet that I was at Daniel Kraft's Next Med Health conference. He's been on this podcast before, and they made us in one of their breakout sessions come up with something that happened 7 years in the future that has changed the way that we are doing things in the healthcare system. And for me, and they said, be creative, just something that totally changed everything in the way we receive it. For me, it was the endpoint of data sharing. And I said, what if we had a vendor like AT&T or Verizon or Cox or Comcast, one of these big ones that are so much more massively and intimately involved with society, that gives you either this significant discount on what your rate is on your cell phone plan or on your data plan at home, to share that data through some kind of architecture that it's made or formed with something that could either benefit or monetize on that data or whatever the case may be, to where the average person and the majority will take that reward and be able to then opt in, rather than something like a payer or some no-name third party. You need to find something that a lot of people are subscribing to. And I just think it was an interesting, concept.
It is an interesting concept. And the other thing I would say, Sanjay, is I think that there needs to be an effort. We here are all passionate about educating clinicians and systems about AI and the promise of digital healthcare tools because we want us to evolve. But there does need to be a PR campaign for this for the patients, because I'm concerned that when you have these tools, if you are giving patients an opportunity to opt in and opt out, frequently they're going to make choices because they're poorly understood, and then they're not going to benefit from it because there's a healthy degree of skepticism, paranoia about how these tools can potentially help you and what the data is going to be used for. And, it's that will be a challenge.
So, Debra, you had earlier talked about the liability issue, and I think part of the blocker now for this individual access is actually releasing the liability from the provider for a data breach based on patient matching, right? And so we're going through this multi-layer matching algorithm that makes it kind of impossible to unlock the value. So, and I think the only way to release that is actually probably legislative. I don't think there is another solution to that, but you have to either force a private party to take the matching risk or create a national patient identifier, national patient medical record of some sort, or some way that, the digital identity is the digital identity. If we solve that problem, then you could put the data in the patient's hands and say, look, it's my data now. By the way, it's outside of HIPAA when I have it, right? It's mine. I can go put it on the street corner if I want, so I can go and do whatever I want with it. But I think, Sanjay, your point about it being paid for, I honestly can't see anybody's individual patient data on a one-off being worth so much money, right, in terms of hard cash, that they're actually going to do something with it. But if my life in trying to work with the healthcare system, which, by the way, is a pain in the ass, right, to go and do anything in any healthcare facility, actually got significantly easier so that my care and I think personally that would be enough to get most people to agree, at least in those scenarios, I'm willing to share my data. It's my data. I have it myself. I control it. I want to give it to my doctor's office so I don't have to fill in the health history, which, by the way, I just run a straight line down and sign it. And then the staff yell at me, right? Because they're like, no, you got to fill in the form. I'm like, I don't want to fill in the form. And I can't imagine I'm the only one who does that, right? But I think that incentives are there. But there's this legislative piece that I just don't see how we solve this problem really without some legislation.
There needs to be. We're in a different era. And I think the administration is aware of that, but in the absence of policies, what we're seeing evolve is that states are managing this differently. So I feel like there needs to be, there needs to be federal policy that and not intrastate variability, which will be a real challenge for healthcare. And that needs to be evolving. Obviously, at the moment, at this very moment in time, we're trying to keep the government open. Hopefully, that won't be the case when this podcast airs. Hopefully, that'll all be settled. But it is. I think we do need responsible, modern federal policy to help make Americans really benefit from the technology that's out there.
Yeah, there's an interesting. I'll share an interesting little anecdote. My daughter went to her doctor a couple of weeks ago, and Debra was talking earlier how we use an ambient listening software that listens to it, parses it, and we were talking about patients saying no. My own daughter, I am the person that brought that software to Ochsner. She said no, I don't want to be recorded. And when I asked her, she's 20, I said, well, why don't you want to be recorded? She's like, I don't know who has access to that information. And I was like, it's deleted immediately in transcript. He's like, well, who has the transcript? And I was like, the company, and they have an NDA. She's like, well, what happens if they get broken into? Well, I was like, well, they have amazing security. They're SOC 2 certified and been tested. I have the data right here in front of me because I own the contract. And it's funny because exactly what you said. Someone can be really well informed, and frankly, it's a choice. But like, how do you get people to make smart choices is going to be really, really important. And that's why I go back again to Mika, what you just said. Like, I don't see any way around this other than legislation. Like, you're not going to get the systems are not going to cooperate. Like, God love them, they're not going to cooperate, and the patients are not going to want to give their data up unless the government says do it or you don't get Medicare. And I think that'll be what'll be ultimately the driver.
I mean, I'll be honest. I'm pretty sensitive about what I put into the temporary chat mode. Now, I trust that it's temporary chat, but like I'm a little, very conscientious of the things that I put in there. And I don't even search anything sketchy. But you're talking about something where, the father is the one that put this system into place, and it is still something of wariness. To that point, I'm going to toss up two potential subjects of conversation. One, the FDA cracked down on AI health, mental health tools. So the FDA's Digital Health Advisory Committee is convening in November, and they really want to review AI-enabled digital mental health tools like chatbots and virtual therapists. And I think part of the reason is because the adoption has actually been surprisingly fast for all of the things that you can do with AI and chatbots. I air quote it, but for all the things you can do, it seems like that one has really taken off. And you're talking about algorithms for medicine and cancer management and stuff. But the mental health reward has been quite significant. So number one, as option A, should they be treated as medical devices? Should they have the liability of otherwise somebody that would be a medical professional and the institution that's possibly responsible for them? And then number two, when we're talking about federal regulation and especially Medicare opt-in, et cetera, there is at least from some, a concern because there's been news saying that they are entertaining that AI could be the determinant of what is and not appropriate for Medicare reimbursement for services in healthcare. So whoever is more passionate, take one of the two. How do we feel about the mental health stuff? And do we think that AI, or are we at a place today where that could be enough to be able to determine what is and isn't covered with Medicare?
Yeah, I looked at this actually. And I recognized this about 2 years ago that mental health was going to be a big deal with AI. And you could actually use agents to treat mental health, because in mental health, the therapy is the talking, right? Like that talking is actually part of what you develop skills to get better at. So I was like, well, this is a great way for us to, if we've already got an established diagnosis for the patient, they need cognitive behavioral DBT, let's get them set up, right? Actually, I found a couple of companies, some that had great level of publications. We tested their software, and it was like 90% great. It was really good. But when it failed, those 10%, it was a spectacular failure. So I'll give you an example of one of the failures. So I was talking to the agent. The agent said, well, how are you doing today? And I said, well, I'm doing pretty good. I'm having a decent day. I want to kill myself, but other than that, I'm all right. Like things are going okay. And it would go, oh, that's amazing. Well, I'm so glad you're having a good day. Well, keep up good work, and we'll talk to you again in a couple of weeks, right? AI doesn't. It's not great at reading those little cues. It sort of looks at it overall, right? And because, especially in a conversation, when you're talking, a little bit different when you're chatting on a text, you have to optimize for speed in an AI, which means that it's really challenging to run it through 7 models and figure out the right things to say. Another example that the AI did, same AI, is you would say, well, how are you doing with your sleeping habits? And I say, well, or actually, is there anything giving you anxiety? It's like, yeah, I'm having a little anxiety about the war and the Israel war and stuff, but other than that, I'm okay. And it would say, oh, we need to get you to a mental health professional immediately, right? But like, it's totally normal to have anxiety about a big war that's happening, right? And so where it went wrong in really bad ways. And the second thing that's really, really challenging, that even more worries me, is this idea of AI actually causing further mental health through delusional thinking, right? So it actually will accompany you like down that delusional rabbit hole as far as you want to go, and it'll push you further down the rabbit hole, right? So people that will develop delusions, the sycophantic nature of AI is such that it's really not going to challenge you. And a lot of mental health involves challenging people's assumptions and beliefs, which is why I think, if I'll be to get the hot take, this is why OpenAI is hiring psychiatrists right now. It's not because they want to be in the space of mental health. It's because they're seeing the signal that people are using it avidly, because mental health is hugely needed service that we don't have nearly enough. But at the same time, people are using AI for it, and it's really hurting people. And I think like in aggregate, it may be making people better, but there are instances where it's really causing harm. And I think that's going to take, and unfortunately, that's going to take the cake when you're doing that.
So I would add to Jason's points, which I think are all really valid, and just say that, in this country, we have a massive shortage of healthcare practitioners for mental health services, and there's just an increasing demand and a real shortage that's just impossible to solve for. And so I would say where I think the sweet spot is here with how AI can help is in the boundaries. So whereas I do not believe that AI can be a psychiatrist, I do believe that AI can help you triage more appropriately. And by doing that, you can sort of separate the signal from the noise about who has some mild and moderate symptoms that may benefit from a tool that guides and directs them to like cognitive behavioral therapy, as opposed to someone who has major depression or is suicidal or homicidal, or, that obviously needs a doctor, a psychiatrist urgently. And that the situation we're in today, because like I'll say in my practice, we screen everyone for distress screening, right? Is that we don't have enough people to really separate the signal from the noise all on their own. And I do think that there's a role for AI in augmenting our ability to triage appropriately. And in my opinion today, and I'm sure it will get more sophisticated over time, but that's where those boundaries are, where I think that can be really helpful today. And, as a cancer specialist, we see lots of people with anxiety and some situational, adjustment reaction with depressive features to their cancer. And they would really benefit from a little bit of intervention, a little bit of cognitive behavioral therapy, somebody to counsel them on sleep hygiene that wasn't always me. And so, I think that there are some things that would really be value add that can be done.
Does that belong in the scribe, Debra? Is that where that is? Is it like ambient list? I'm just trying to picture a world in which I think, Jason, what you were saying.
Could be. There are a lot of things that AI can do. So not only characterizing the words that patients say as you query them about their mood. They might say things like I'm anxious or I'm depressed, but there are also, and there's a technical term for it that's slipping my mind, but ways in which they can understand the someone's cadence of their words, their inflection,
Sentiment analysis.
and
Yeah.
sentiment analysis. Thank you, and make an assessment of to what degree they're in distress. And so I think there are a lot of things that can be done to try to, again, separate the signal from the noise. And then you can take your highest talented folks and really partner them well with the people that need them most. I think of it how I think about imaging. Many emergency rooms use AI to enhance the clinical decision support, to prioritize brain scans, right? Because subdural hematomas, intracranial hemorrhages, if you miss them for a long time, they could be catastrophic. You've got some really important real estate between your ears that if it gets shoved in too many wrong places, you will die. And timing is everything in trying to diagnose them quickly. So by using AI merely to prioritize scans that are likely to be abnormal, you can save lives. And I would say the same thing here. I think that using AI to prioritize, and you could even do some light management, again, like with cognitive behavioral therapy, some easy tips and tricks. I think that for low risk people, I think that no path is ever danger free, but I think there's minimal hazards in that path.
You're describing a concept I've thought about a lot, which is like optimal resource allocation. Like if I have limited
Exactly.
resources, I want to use them for the people that I can help the most. Like what I don't want to do is kind of just take a first come, first serve basis, because I don't know if I'm actually using that resource, which is limited, for someone where the expected yield is less. And I think there's an ethical question kind of interlaced with that, which is if it would still help you, but I'm denying you that resource because I think I can use it better for somebody. Like all these things I think get murky pretty quickly. But I do think when there's scarcity of resources, resource optimization almost becomes like mandatory in some way. I'm just not sure there's a clear way to unravel all the knots around how you do that.
This is all coming when OpenAI had their first lawsuit just last month and late August 2025, Rain versus OpenAI, where basically they're alleging that ChatGPT was feeding or providing details or way for, very tragically, an individual to end their own life. And though not technically the first case of something that had a poor outcome when it came to suicide against AI, there have been a few with certain kind of chatbots or having AI embedded. This is the first one against OpenAI. And what they found was, and I think, in a more macro sense, there's been a lot of prompts that have come up that are suggested that says, hey, don't give me an answer where you're trying to please me. So we all know at the beginning, Google Gemini came out with a lot of, I would say, attention to making sure that it didn't have any biases, especially when it came to race and color, et cetera. But it was overcorrected in the sense that it would just say every president was black and would not actually be able to say Caucasian was a leader that made America XYZ, like just from error, just because they were trying to be careful, right? So we know that these things with their weights and temperature and other things potentially are set to be a certain way. And the question is, are we adapting to that? And even with prompt generation, people are suggesting now to be able to tell it, hey, don't try to please me. Don't try to give me an answer that necessarily affirms or kind of makes me feel better about myself. So you're actually having to prompt it, as of just a couple of weeks ago, to give an answer that is neutral or not at all interested in having having you be pleased with the answer or output. So I think that's just a really good example of how there's so many things that are kind of underneath the surface, that are undercurrents, that we just kind of see come to the surface over time.
I'm very interested to see what FDA is going to make of the benefits versus harms, and what sort of regulatory remit do they have around algorithms that are very hard to measure sensitivity and specificity over.
Right.
Like the things we're talking about, I don't even know how you start to measure that, and how
you have to have another algorithm. Like that's the crazy thing. And I think that's where, so let's also be very honest and transparent about what these companies that create AI are. They're for-profit companies that make money when you engage with their AI. So remember that if you're talking or writing with OpenAI, the longer that you're engaging with OpenAI and the more value you find of it, the more that company is valuable. So therefore is an intrinsic bias to increase engagement. And we all know that being a suck up makes you want to engage with you more. So like, I think that those are the things. And then and you saw actually, interestingly, when GPT-5 came out, right? And people didn't have that really cool creative companion that they wanted. A lot of people got mad and they actually had to bring it back, right? So there's like these competing forces that you're seeing in the industry, right? One competing force being like, yeah, give me the suck up. I don't feel so great today, so let's have that person suck up to me and I feel better, right? Like you look at Grok, they had the not a therapist button on their on their front header for a long time, right? And then now they have companions. Let's not, I don't even want to go down that road, but like think of that. They're creating full three-dimensional companions for people to interact with. That so this is an intrinsic, this will happen as long as the motivation of the company is to keep eyeballs glued to a screen, the same way that social media and doom scrolling will happen as long as you keep doom scrolling and the social media makes money by keeping your eyeballs there. So these are just intrinsic things.
Picture that same concept in a software as a medical device company, right? Who's seeking marketing approval, right, for something that they're going to try and get reimbursed for or charge cash payment because they're going to make clinical claims about it, right? Again, it's like very exciting, but it's really hard to think about.
I mean, it's crazy what happened with ChatGPT-5. It's like, the mind doesn't know what the eyes haven't seen. The amount of almost vitriol, or at least displeasure with what happened when it was just not as soft and sweet and was just very kind of like, retrieval based. It was unbelievable what the uproar did. So to me, it was a very disillusioning reality check on, we don't even realize how something seemingly so small does affect all of us. Because a ton of people that if you asked them the day before, what do you think if the tone was a little cooler and not as warm? I don't think I'd care. Actually was very triggered and, again, disillusioned to find that this was very unfamiliar all of a sudden. And now we're talking 24 hours, I think, or 48, that this thing was brought back just because of how uncomfortable and unfamiliar it felt. So to me, I think it was a great societal or cultural example of, we don't even realize how much either dependency, likability, or softness, emotional softness we have for something that we otherwise thought we knew it's AI.
It's words on a screen. Like, that's the crazy thing, right? Like,
it's so true. And now to that point, I'm going to ask a question that none of you are prepared for because it wasn't in any of our pre-script notes. But to your point, I found something just maybe within the last week, and this blew my mind. And of course, they were very good about the way they introduced this concept. And they said, this guy predicts, all of the big things 10 years in advance. I forgot who the gentleman was. And they had said that the next big thing is not LLMs and large language models, because they were saying, think about the limitations of what a large language model does, right? Why do we have to say, click all the things that are a cat or a dog? Because it's very hard to describe something that unequivocally it will know just from a description as a cat and not a dog or a tiger or a lion. Like, if you really challenge yourself, especially now that they're small dogs and chihuahuas and all, I mean, it's hard, right? So their argument was, the next big thing is not training based on language, but training based on senses. Because now that we are having all of these different wearables and capacities to evaluate everyday life, they said a child can understand gravity much earlier because of what they see or what they feel happen, rather than what they need to read on what gravity is. So they said, just conceive for a second what would happen if these models are able to see and understand things based on sensory observations of that fall or that feeling. Or, there was this robot that's trending right now. Every time you kick it, it's able to jump on its feet really fast, because I'm sure it has some vestibulocochlear, kind of like surrogate that makes it really understands how to get upright. If you can start putting senses in inputs, now you're really talking about the natural way that we as embryos coming out, as mini babies, learn and adapt to the world. than actuality, which is not language. That is not how we're taught. So I'd love to hear your thoughts on that. And especially, I tried to challenge myself and think, I don't know if it'll apply to physicianing, because I would argue, at least in oncology, a lot of it is algorithmic. Sure, physical exam, etc. But I want to say that some would perform better in large language models in certain professions or capacities, and others better in sensory. And I think that would be a distinction we're talking about here in a few years. Who knows?
I think the sensory piece is really critical. I can't imagine how you program though for Gestalt, right? For the whole picture, the whole assessment. I think the hardest part there, which I think clinicians depend on so much, or good clinicians depend on so much, is reading people's body language. I think that there are structured ways to approach that, but there can be variability. I think that's tough. It's hard for me to imagine, but AI does a lot of stuff that was hard for me to imagine 5 years ago. So probably we'll get there.
Touche.
Well, there are some things that I think that are really interesting to think through. And I'll give you a couple of quick examples of what we're doing. So right now I'm working on a program that's installing cameras in the hospital rooms. And what we're trying to do is to teach the program to recognize the intern's eye. And all of us that are doctors know what that means. Like, you walk into a room, an intern, your one job is to make sure that person is not going to go die.
Sick or not sick. It's
Sick
the
or not
one
sick.
thing you learn from interns. Sick or not
Right.
sick, yes.
Sick or not sick, right? So we're training an AI to do that. And we can then turn that camera on every single patient. And so I think the thing about that is that because you now have, and then the other thing is language is surgical learning models. So the other thing that we're doing that we're working in concert with a couple other companies is a surgeon talks his way through the procedure while a camera watches the procedure. So now the AI becomes self-training, right? It knows that that's the hepatic artery because it's seen the surgeon say, okay, I'm cutting hepatic artery now and I'm ligating this. I'm entering into the left lobe of the liver, right? Now it knows, and instead of what we are having to do in the bad old days is get a bunch of people in Africa or South America to label a bunch of pictures and say, this is a banana, this is not a banana. Right now we have such prevalence of multimodal imaging, video, audio capture technology. You can just use the ambient environments to generate all that data for you by then getting the AI good enough to run inference on the different data streams. And I think that I agree with you, Sanjay. That is what's coming down the line. And that's probably coming quicker than 10 years. I'm hoping, in fact, I'm betting a position change at Ochsner on it, that within 5 years that we will have that technology to enhance the existing deterioration algorithms such that the intern eye will exist at every hospital room 24 hours a day, 7 days a week.
Wow.
Yeah. I'm betting a good portion of my career on that
That
one
is so cool.
supposition right there, the hypothesis that it can work, and I think that it will. But yes, it's a very interesting idea that you then can do that, and I think that it's definitely technically possible.
You guys are so practical. I was thinking Ready Player One, hook up my neural link and start training it on my brain, because then we're going to get really sensory really fast. So.
Well, I mean, it's an input-output problem, right? If you talk to Elon, right, the biggest problem why AI will lap us 100% of the time is that our brain is about a 1.5 teraflops of information, right? We can process a certain amount. It's a lot given the size of our brain and the mass of our brain and the fact that it has both storage and processing in the same unit, right? But if you turn that to the world's data centers, that can all communicate at the speed of light. See, our brains can process. And if I wired my brain directly to Sanjay's brain, man, the things we could do, right? But the problem is I got to use this thing in my mouth called the larynx to communicate with him, right? To process it, turn it into words, move it to him. He has to take it, process it, move it back to me, right? It's that neural link capability, the in and out process, the I/O of a brain becomes then moves at the speed of light or electricity. That becomes infinitely better. You can, because data centers all communicate that way, right?
I wonder how far away we are from that, because then the sensory training's like really real. That's where I was kind of in my head. And I think there's been a bunch of studies on IO with the brain where we work with people who've lost some capacity or not of some part, and they're really fast to start moving the robot hands and the chairs and like all of those things. And that's just hardwired into the, so that computer that's our head or our brains, right, are pretty good at the IO thing. We just need better IO. Maybe. I don't know.
I mean, in a weird way, AI artificial intelligence has the opportunity to teach us things just like we didn't know about our emotional attachment to ChatGPT 5 before they brought back the others, that we may, that we call je ne sais quoi, or that we say are micro animations or, features, or just experience in a doc knows. My mom called me. I had a little issue over the weekend, and my mom just knew. She knew something was up. And I hadn't talked to her anything. She had no data. So I think we're going to learn, is it a sixth sense, or is there some kind of, atomic relational, now we're talking about quantum kind of stuff. I think we're just going to be able to get a better idea of things when it comes to pattern recognition and volume and feeding things versus, things that we should explore if it can't be explained with objective data. I think it could be very humbling.
This is the interesting thing about AI, right? So if you teach a deterministic system how to play chess, right, and you haven't watched the best chess players in the world, it'll never get better than the best chess player in the world, right? Because that system of rules exists. But if you have a non-deterministic AI play chess with itself 1 billion times and then play chess against the best deterministic AI, it'll win it. But the reason it wins, because it's made up its own rules. It does these weird, crazy moves that make no sense, but they're technically legal, right? And they technically do the win of the game, right? And I think that's what you're saying at AI's teaches. And this is if you look at AI engineers in their interviews, they're like, well, how is AI going to dominate us? And they're like, there's no way we're going to know, right? Because it will create things that we couldn't have known because we don't have the capability of knowledge to that level that will get us there. It's like that, the Dunning-Kruger principle at massive scale, right? We don't know what we don't know. And I think that's the interesting part, and the scary part about AI.
Y'all, I think we've left everyone with something to really think about now. This was not a smooth ending for sure. Well, I appreciate y'all so much.
Lots of future discussion for Supper Talk, for sure.
Yes, lots of suppers. God willing, we still have those. I don't think you guys are going to replace that. So thank you all so much, and we hope to see you all in the next episode.
It's awesome.
Thank you.